From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, JAMA Surgery listeners. This is Amalia Cochran, the web and social media editor for JAMA Surgery. And I'm here today discussing restrictive versus usual care in patients with gallstones and abdominal pain with Dr. Daan and Dr. Philip de Reuver from the Radboud Medical Center in the Netherlands. Thank you both so much for making time for us today. I think it's important for us to start by providing a description of the two randomization groups in this study so that listeners don't just assume that this was as simple as operative versus non-operative treatment of symptomatic cholelithiasis. Can you walk us through what you all mean when you use the phrases restrictive versus usual care?
Yeah, thanks. This is one of the main headbreakers in the development and the design of the initial study almost 10 years ago. Initially, the idea was to randomize patients between surgery and a non-operative strategy. However, this would have two disadvantages. One, the outcome of the study would not learn us how to better select patients for surgery, but only the effect of a lab colleague. And second, the support for such a study among the surgeons and patients might be rightly so, limited. And we know, until this day, laparoscopic cholecystectomy is the gold standard treatment for patients with abdominal pain and gallstones. So therefore, in the SECURE trial, we randomized to either usual care or a restrictive strategy. And in the usual care selection for cholecystectomy was left to the discretion of the surgeon in combination with shared decision-making with the patient. And in the restrictive strategy arm, stepwise selection for cholecystectomy was performed. And in the restrictive arm of the study, cholecystectomy was advised when patients fulfilled all the predefined 5 selection criteria for cholecystectomy of the triage instrument. The triage instrument was based on the 3 Rome criteria for biliary colic and 2 additional symptoms recorded in literature as predictive for biliary pain. So the 5 criteria in the triage instrument are 1. Severe pain attacks, 2. The pain lasting for 50-30 minutes or longer, 3. Pain located in the epigastrium or right upper quadrant, 4. Pain radiating to the back, and 5. A positive pain response to a simple anesthetics. So with this restrictive strategy in the study, patients and surgeons were more willing to collaborate, and at the outcome of the study, it would tell us if a restrictive strategy is associated with better patient-reported outcomes. So, yeah, we think that this is a good explanation of both arms.
Thank you. I think that differentiation is really important for both readers and listeners to understand. I do want to talk a little bit about your process with this clinical trial. You all have previously published the 1-year outcomes for the patients who were enrolled in the SECURE trial. Why did you think that this 5-year follow-up was also important?
Thanks, Amalia, for that question, because it's a long project now. In 2012, or more than 10 years ago, the SECURE project was funded by the Dutch Ministry of Health, Welfare and Sport in collaboration with the Dutch healthcare insurer. And the funding party advised us that the project would run for a maximum of 4 years. Because of the admin in all collaborating hospitals, 24 Dutch hospitals, and patient inclusion, which would take a significant amount of time, we decided that the initial follow-up to the trial would last only for 1 year. While within our group, we already anticipated that the long-term outcome would be of, greater interest. The main outcome measure of this trial was abdominal pain, and it was well possible that this patient-reported outcome would convert over time in a longer period. Additionally, waiting times for surgery vary among participating hospitals. While some patients could be operated within weeks, others might wait for several months. And finally, we were uncertain if we would catch all relevant secondary outcomes with 1-year follow-up, such as the development of recurrent colics or biliary complications. So the initial 1-year follow-up of the SECURE trial was pragmatic, but may have been too short to capture the true long-term outcomes. And issues such as patient crossover from a conservative management to a surgical treatment and the incidence of late biliary complications could well impact the effectiveness of our restrictive strategy. Well, so therefore we're now grateful that JAMA Surgery publishes the long-term outcome, as it reveals two important findings, to my opinion. I mean, only 2/3 of patients achieve pain-free state after laparoscopic cholecystectomy, even after 5-year follow-up. And secondly, it really shows that a more restrictive approach could be adopted to avoid unnecessary surgery, and the trial shows it's safe.
On the heels of a large pragmatic clinical trial like this, I'm always particularly interested in the implication for clinical care. From what I'm hearing you all say, you've almost got me well convinced that we shouldn't necessarily be doing laparoscopic cholecystectomy for patients with symptomatic cholelithiasis. And that leads me to ask if your findings from this have impacted your clinical approach to the management of symptomatic cholelithiasis.
Well, first, to be honest, international guidelines advise laparoscopic cholecystectomy to treat patients with symptomatic cholecystolithiasis, but it results in an enormous amount of surgeries, over 750,000 in the United States annually. While this trial shows and confirms that 40% of patients continue to have persistent abdominal pain despite the surgery. And these patients generally do not report their persistent pain to their surgeon. In the Netherlands, they consult their general practitioner or they go to a gastroenterologist. While this persistent pain affects their quality of life and generates a substantial burden on our healthcare systems in terms of costs and capacity. And until recently, there was no international consensus on the indication of cholecystectomy in these patients. And the indication varies globally. So after the publication of the short-term results of this trial, we questioned ourselves, according to which criteria should patients with gallstones and abdominal pain be selected for surgery? And these questions partially answered, and the outcome was published in the JAMA Surgery in October 2021, because we tried to answer this question in the SUCCESS trial, the successor of the SECURE. In the SUCCESS trial, we analyzed data from over 1,500 patients and developed and validated a multivariable prediction model to predict clinically relevant pain reduction after surgery. And this model showed that older patients and those with no history of abdominal surgery, an increased baseline visual analog pain score, and pain radiating to the back, pain reduction with simple analgesics, patients with nausea and no heartburn had a higher chance of success after surgery. But to answer your question, yes, I do think the SECURE trial will impact our approach on symptomatic cholelithiasis. The extreme increase in lap choles since the 1990s will probably stop, and maybe we will be able to bend the curve and only provide cholecystectomy to patients who really benefit from surgery. Surgeons and patients should be aware that although cholecystectomy might provide relief from biliary colic, it does really not treat non-biliary abdominal pain.
Daan, I'm curious, why was it important to conduct both intention to treat analysis and a per protocol analysis for this particular study?
So for a pragmatic clinical trial as the SECURE trial, it's relevant to report both the intention to treat analysis and the per protocol analysis. The combinations provide the most comprehensive view of the intervention's effectiveness, where the intention to treat will highlight biases and reflect a real-world application due to crossover from arm to arm. The per protocol can show the treatment's efficiency among compliant participants. So we'll take a look at our study and the initial findings of the initial SECURE trial. Approximately 30% of the patients in the restrictive strategy did not adhere to the prescribed protocol. The majority of the protocol deviations occurred in patients who underwent cholecystectomy without meeting the pre-specified criteria of the triage instrument. So the decision to operate was often influenced by either the surgeon's judgment or the patient's preference. And this is what happens in real life, and we know that laparoscopic cholecystectomy is an example of preference care, and therefore should be shown in a study like this. So, I think this is a reasonable explanation why we performed both analysis.
What finding was the most surprising for you all?
Two things. First, we failed to develop a successful intervention. Our restrictive strategy was not as successful as we initially hoped, and even in the restrictive arm, 40% of patients report abdominal pain, even after 5 years of follow-up. Other retrospective studies reported this high number of patients with persistent pain, and we were still surprised that the SECURE confirmed these striking percentages. So, in the end, we don't think that our surgical community is aware of these numbers. Secondly, as we look in the restrictive strategy, this kind of selection strategy is not associated with increased biliary or surgical complications, as only 1% of patients developed a biliary pancreatitis and no severe pancreatitis was observed. So therefore, it can be interpreted as safe.
Philip, I would appreciate it if you would expand a little bit when you talk about the basis for this continued pain even after cholecystectomy.
Well, that's interesting because several studies have shown the high prevalence of functional dyspepsia or irritable bowel syndrome in patients presenting to us with gallstones. And we showed that more than 1/3 of patients with gallstones eligible for lab chole comply with the Rome 4 criteria for these functional gastrointestinal disorders. And in a previous study we published, we performed a 6-month follow-up in over 400 patients with gallstones. And that study showed that patients with functional gastrointestinal disorders undergoing a lap chole are 2.5 times less likely to be pain-free compared to patients without these disorders. So this points out that it is very important for a surgeon to differentiate between biliary colic and other functional disorders in order to properly select your patients for surgery. And you could maybe ask your patients to come back in 3 weeks and really make a diary on what the symptoms actually are, and then decide together if surgery is indicated.
So I think at the end of the day, what you're advocating for is that we take a very individualized, personalized medicine even approach to patients who are presenting with symptomatic cholelithiasis.
Yes, I do. And hopefully the tool we developed can help. And it's always a shared decision with your patient. But the lap chole shouldn't be the quick fix for abdominal pain.
Thank you very much. I am Amalia Cochran, the Web and Social Media Editor for JAMA Surgery, and I've been speaking today with Daan and Philip de Reuver about restrictive versus usual care in patients with symptomatic cholelithiasis. You can find a link to the articles in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks for listening.